Hi, I'm Mimi Winsberg. I'm the Chief Medical Officer of Brightside. We're a telemental health provider that offers innovative tools to treat multiple behavioral health conditions. And I'm going to talk today about the state of precision treatment in mental health, what our current solutions are, and what opportunities are ahead. So I'm going to share my screen here. And go into presenting mode. Here we go. So yeah, I'll talk today about precision treatment for mental health, what our current solutions are and opportunities, and I'll tell you a little bit about what we're doing at Brightside to move the needle in this regard. What we'll go over is what the current treatment of mental health conditions looks like and why it lacks optimal efficacy or specificity. And then we'll talk about how precision treatment may hold potential to address some of these issues and move mental health care into the next era of better outcomes. We'll talk about what some of the key ingredients are to get there in terms of what tools we have for precision treatment. And then we'll look at what Brightside is offering in terms of precision care today and how that's contributing to our industry-leading outcomes. So why are current outcomes suboptimal? Well, we know that current drug treatments are successful in only about half of patients. In the STAR-D trial, which was the largest antidepressant trial that was conducted, only 49.6% of patients responded to treatment. And we know that 30 to 50% of patients with major depressive disorder don't respond to their first antidepressant. We also know that non-responders don't fare as well. For instance, they have a higher likelihood of suicidal ideation as compared to those who are treatment responsive, 15% in the non-responders versus 6% in the treatment responsive group, vis-a-vis 1% in the general population. And while we have good treatments, we have over 200 drugs that are available for the treatment of psychiatric and neurological conditions. Most prescribers are only choosing from a short list of 3 to 5 treatments. Part of this is because a large majority of antidepressant prescriptions are issued by primary care physicians, and they may lack the depth of knowledge or expertise to prescribe from a longer list. But despite that, even psychiatrists may not be accessing the number of permutation of treatments available in some cases. And so what this tells us is that using telemedicine to increase access to this quality of care is really not enough to move the needle in terms of solving our mental health challenges. We need to not just focus on access, but also focus on quality and incorporate some of those tools into our telemental health tools. The current limitations in practice are partially because psychiatry has relied for decades on the DSM, the Diagnostic Statistical Manual, and that diagnoses are made based on a list of symptoms, and that can lack scientific basis or data associated with it. For instance, major depressive disorder, the diagnosis is made by having one of 2 primary symptoms and then having to have 5 out of 9 total symptoms. And so if you think about the number of permutations involved, 2 patients could share 1 or 2 symptoms and still have the same diagnosis. And so a lot of these guidelines, these broad and general treatment guidelines, fail to account for the heterogeneity in these conditions. Even major depression, as we've seen, is quite heterogeneous when you superimpose other conditions like anxiety on top of it or varied family history. You get into a lot of different data points, and taking a uniform treatment approach can result in a regression to the mean in treatment. In addition to that, we know we have few known biomarkers. So we lack the biologic markers that other fields have in treating their illnesses and conditions. So this is an additional limitation in psychiatry. Finally, because of the heterogeneity of these conditions, and because patients are presenting with a lot of multidimensional data, we know that classical statistical concepts may fail us in dealing with these huge data sets. It can be difficult to extrapolate patterns or draw a relationship among all of this multidimensional data just in a clinical trial. So what we need is a more sophisticated way to do data analysis in order to better understand treatment response and precision in fields like this. So I think we've concluded that treatment today can sometimes be, and largely be, a process of trial and error or guess and check. What our goal is to enable clinical prediction on an individual level for a patient. And the notion behind precision care is that it could support a differential diagnosis. In other words, elucidate details of a diagnosis and make it more precise, and even predict a therapeutic response in a patient. That might be their outcome. It might be whether they'll have side effects. It might be who will respond to a first-line treatment, which one, who might be treatment resistant. And oftentimes we're faced with the decision of switching treatment or augmenting treatment. And perhaps there could be more precision in terms of knowing whether this involves a dosage change, a switch in medication, or an augmentation. Lastly, it might be helpful in determining an individual's risk based on certain features that they might have. There are 4 key ways that this precision approach to managing patients is taking shape. And we'll talk about all of them. So the first 3 are in terms of predicting treatment response or outcomes. And the first is phenotype. So thinking about what is the particular signature of a patient as they come in, what is their phenotypic presentation, and how might that dictate outcomes. The second is what is their genomic data, so not just their phenotypic presentation, but their genotypic presentation, looking at their pharmacogenomics in order to predict treatment. The third are peripheral biomarkers. And the fourth is on the level of treatment management, that is to say, remote patient monitoring, including passive measurement of data. So there may be symptoms that the patients are reporting, but there may be symptoms that we can passively draw to. And we'll talk about all these different things. So first, on the level of phenotypes, that is to say, observable characteristics. As we've said, patients are coming in with multidimensional data. And in order to understand how patients come in with particular set of attributes and what treatments they might be responsive to, we have to use some form of data analysis that's sophisticated to be able to draw all these associations. So machine learning has the ability to look at a data set, a large data set, and without using explicit instructions, uncover predictive associations in that data set, looking at structured data. With deep learning, it can do this using unstructured data. And so one of the things we can do by feeding a machine a large data set of patient attributes, treatments, and outcomes is we may be able to reveal biologic subgroups that are contained within that data set. So some patients may prove to there may be a biological subgroup that's not yet defined by the DSM, for instance, that becomes visible through that data. And what we've also seen is that we're able to generate risk stratification based on patient self-reports. So symptoms may enable us to generate risk if we're able to look at the data in a sophisticated way. And in addition to predicting treatment response, we also may be able to predict treatment behaviors, that is to say, adherence to a particular regimen or other features of behavior and treatment. On the level of pharmacogenomics, we know that some pharmacogenomic data seems to be helpful in the sense that a couple of studies have shown that using genetic information, particularly the enzymatic pathways of the CYP2D6 and CYP2C19, can really improve response in patients after 8 weeks of antidepressant therapy. So we have data showing that patients receiving pharmacogenetic guided therapy were more likely, 1.7 times more likely to achieve symptom remission versus treatment as usual. The problem is that meta-analyses have indicated that this data is still variable and maybe not ready for prime time yet. In order to be useful, the genetic data has to be clinically actionable. We know that with CYP2D6 and CYP2C19, for instance, we can see if some patients are fast metabolizers of drugs or slow metabolizers of drugs. So that may help us choose a dose for a patient. But in terms of the genetic data being able to guide our treatment selection, we're not quite there yet. We'll need future large sample size randomized controlled trials, and we need to figure out a way to combine the genotyping with clinical decision support so that it can give providers guidelines without necessarily having an exact answer. I think the conclusion is that genomic data holds promise, but still has a little ways to go in terms of being able to drive predictive medicine, precision medicine. We also talked about non-genetic peripheral biomarkers, and we know that there are a number of peripheral biomarkers that may be helpful in terms of differences that we see in mental health conditions. These non-genetic peripheral biomarkers tend to be shared across diagnostic categories, so they have a transdiagnostic nature. We'll talk through a few of them. We've seen that euthymic bipolar disorder patients show a higher cortisol awakening response relative to controls. C-reactive protein, which is found to be increased with peripheral inflammation, seems to be increased in euthymic bipolar disorder, in addition to bipolar mania and major depressive disorder. Soluble IL-2, interleukin-2 receptor levels were increased in major depressive disorder and schizophrenia. So you can see there's a common theme here that these are not exclusive to one diagnosis, but are transdiagnostic. We also have seen that BDNF levels are decreased in major depressive disorder and Alzheimer's disease, and that insulin-like growth factor was elevated in bipolar mania and major depressive disorder. Additionally, antibodies against the NMDA receptor were elevated in bipolar disorder and schizophrenia. So while all of these findings are very interesting, there is no biomarker that yet meets criteria for convincing evidence and treatment prediction. So there's no one biomarker that we can use to help guide treatment for a particular diagnosis. I think future directions with these peripheral biomarkers may be creation of a biomarker score similar to the generation of a polygenic risk score. So figuring out how to take into account different levels of biomarkers and coming up with a score that may be helpful in terms of prediction. The last factor that we talked about, or key feature that we talked about in terms of moving the needle with prediction, is passive monitoring. And this seems to hold a lot of promise, privacy issues aside. We can see that there are opportunities to increase signal in what we know about patients through a lot of different passive monitoring techniques. There's voice recognition. There's a lot of signal in voice. We may be able to determine from voice recognition whether a patient, what mood state they're in, or whether they're likely to have a psychotic episode or not. Using natural language processing, we can derive a lot of data from text. There are a number of platforms that are using, including ours, that use text-based therapy. And there's potential data we can derive from that to predict both a state a patient may be in or a treatment that they may be particularly responsive to, or even a style of treatment that they may be responsive to. There's an opportunity to monitor patients' activity, how they're moving around, their social interactions, perhaps what Wi-Fi networks they're on. Any kind of human-computer interaction can be interesting. So there are lots of tools to monitor patients in a frictionless way that may be able to provide additional signal and information about what treatment that they're responsive to. All of these may improve our ability to understand patients' needs, trigger real-time interventions, and measure outcomes above and beyond self-reported symptoms. So to get into things like activities of daily living and objective data about patients that doesn't require their self-report. We'll talk now a little bit about what we're doing at Brightside to move the needle in terms of a precision approach to mental health care. So just a little overview on how we deliver care. Brightside offers comprehensive care in that we provide medication solutions as well as therapy solutions for patients. When patients come in, they go through a digital assessment and get feedback on their level of symptomatology and what kind of care they may benefit from. We determine their eligibility for our platform, and then we do a comprehensive intake where we gather over 100 data points on them, everything from current symptoms to family history to prior drug trials and so forth. They're offered an appointment, a video appointment with a provider within 48 hours, and they can choose from two arms. One is the medication arm and the other is the therapy arm. They can also choose both. For the medication arm, they'll see a provider over video within 48 hours if they choose, and then get a full assessment, at which time a treatment plan is determined. That provider is offered clinical decision support in order to come to that treatment program. And medication is delivered to the patient's door or sent to local pharmacy for pickup. After that, the patient has access to in-app resources and engages in the platform in a closed-loop fashion in order to continuously monitor their care and adjust it as necessary and look for early signal in the treatment that can help guide the care effectively as they move forward. On the therapy side, patients are offered video therapy appointments weekly, along with an evidence-based program that's based on the Unified Protocol. The Unified Protocol was developed by David Barlow and is transdiagnostic in nature, so it can address a lot of different diagnoses using a core treatment program. Patients are given a lesson plan with a weekly practice, and they have daily support from their therapist over text messaging, in addition to their video visits. All patients, whether they're in the medication arm or the therapy arm, are rigorously followed and I should say ruthlessly followed with measurement-based care. So we track how they're doing, and they themselves get feedback on how they're doing and have access to self-care tools. So we're really able to see early signal. We take a very data-driven approach to medication management. So we use what we call precision prescribing. And what that means is when a patient comes in, we gather a lot of data on them and then use our machine to, taking an algorithmic approach and soon to be ML approach, to analyze that phenotypic data and identify symptom clusters. So we identify their particular signature, and based on current literature, can identify what treatment plan they may be most receptive to in terms of what is likely to be successful for them. And so we'll suggest and surface to the provider with clinical decision support certain medications based on their symptom clusters. The provider will use that to guide treatment, and then the patient continues to interact in a closed loop treatment monitoring and optimization program where we measure frequently how they're doing and surface that to the provider based on a rule set that allows the provider to see how the patient's doing, early signal in response to treatment, review the case, follow up as needed in real time, and adjust treatment in real time. And this includes everything from symptom monitoring to side effect monitoring to tracking progress using clinically validated instruments. Measurements are given frequently at first, that is to say weekly, and then as the patient goes through care, those measurements are more spread out to a monthly basis. But this precision prescribing approach, I should say, I'm tripping on my words, this precision prescribing approach really drives what are our phenomenal outcomes. It's worth going over what we treat at Brightside. We are not treating just a mild to moderate population, nor are we cherry picking patients. We treat many different behavioral health conditions: major depressive disorder, different forms of depression, anxiety, acute stress, post-traumatic stress, panic, social anxiety. We treat women through the reproductive cycle. We treat bipolar 2 patients, and can treat secondary diagnosis of substance use or a medically stable eating disorder. Patients that are excluded from our platform are those with psychosis or acute mania, because we rely on the patient to report their symptoms asynchronously, and so psychosis is an exclusionary criteria. We're also not prescribing controlled substances at this time, and anybody who has a complex medical condition requiring frequent lab monitoring is best referred out. But as I said, our precision prescribing yields a long tail of personalized treatment plans. And if you look at how many different unique drug and dose combinations our patients are seeing just in the first 12 weeks, we're seeing over 1,000 different unique drug and dose combinations. So patients are not just being put on Lexapro or put on Wellbutrin, for instance. We're seeing a lot of individual unique treatment plans guided to their specific presentation. Our patients come in with significant symptoms. Our average PHQ-9 score at intake is 18. So we're treating moderately severe and severe patients. We're not skimming off the surface of the mild or sort of worried well patients. And what's, I think, notable is the outstanding results we're achieving with this precision prescribing. At 12 weeks, 81% of our patients see clinically significant treatment response. That is to say, a 5+ point drop on PHQ-9. And 60% have achieved remission level, that is to say, a level under 10 on the PHQ-9. And this includes members with severe depression. You can see in these boxes on the right-hand side that when we only include members with severe depression, we're seeing a really robust treatment response and remission level. With folks with depression and comorbid anxiety, same is true. We see a lot of patients at intake with suicidal ideation, and we're seeing a nice remission of those symptoms at 12 weeks with our treatment plans. And in addition, patients who have chronic medical conditions, comorbid medical conditions, are also doing well at Brightside with a treatment response of about 84% and a remission rate in the 50% range. And these are notoriously difficult patients to treat. So our results really speak for themselves in terms of our approach. And I'll just finish by saying that I think that the future of mental health care really lies in this level of precision. I joke that mental health care doesn't just need to be disrupted, it needs to be erupted. And I think one of the things that makes it so long overdue for change is the fact that we've not been carefully measuring what we're doing, and that we don't always take as rigorous of a scientific approach as we could to how we choose our treatments and the manner in which they're delivered. A lot of treatment happens behind closed doors and is not measurement driven. And I think layering this level of precision treatment can really move the needle, with the potential to dramatically improve outcomes. What's exciting about the future is that if we're able to blend phenotypic prediction and layer on top of that pharmacogenomics, biomarkers, and passive monitoring, we'll get an even more granular view of what a particular patient may need in order to drive successful outcomes. Of course, all of these tools need to be paired with ongoing innovations in care delivery. We've had a huge access problem to mental health care in this country, and telemedicine is doing a really great job of bridging that gap and reducing the barriers to care. What needs to happen right now is lowering that bar to access, but also improving the care delivery, using precision tools to deliver that care in real time with real-time insights that can be put to work in efficient and effective ways and surface to the provider at the right time with patients getting immediate feedback on how they're doing and their symptoms. What we're trying to do at Brightside is to combine these various features so that we have a sophisticated platform bridging access to care along with precise tools to determine what a patient may benefit from. And we think this is the bright future of mental health care. So thanks very much. I will leave this presentation and stop presenting. Thanks so much for having me here at the conference, and happy to take any questions that people may have in an asynchronous fashion. Presenting over Zoom always has some limitations, but happy to take any questions offline, and look forward to connecting with all of you. Thanks so much.